Morning everybody. So it's a privilege to be here, and as Dr. Narayan sir said, we are in the unique position of presenting the last CGR of this term, and we thought we'll be covering this topic of interventions in congenital heart disease because there is a lot to be done in this field and we are trying to do our bit. Dr. Ankit is there, Dr. Naveen is there, who are taking care of primarily the pediatric cardiology aspect. So I'll first of all invite Dr. Sajid will be presenting, and then followed by Dr. Ankit. Yes, so thank you.
Good morning, respected teachers, seniors and colleagues. I am Dr. Sajid, DM third year resident from the Department of Cardiology, and today we shall be presenting our experience of percutaneous intervention in congenital heart disease. So as we go along, we shall discuss the following issues: the definition of congenital heart disease and its global as well as Indian prevalence. What are the broad categories of the congenital heart disease in terms of their functional significance? And this shall be followed by description of few salient features and brief review of the latest available data of surgery versus percutaneous intervention for each of the common congenital heart disease and few illustrative cases from SGPGI experience. So congenital heart disease is generally defined as an abnormality in cardiovascular structure or function that is present since birth, and it is amongst the most frequent of severe birth defects, being noted in about 0.8 to 1% of live births and accounting for 10% of the infant mortality globally. Not only do the patients with complex congenital heart disease often have an extracardiac anomaly, but there is also higher risk of the siblings and offsprings of affected person having congenital heart disease. So on a global scale, the asymptomatic congenital heart disease like ventricular septal defect, atrial septal defect and patent ductus arteriosus are amongst the commonest and accounting for a total of nearly 50% of the total burden of congenital heart disease. Valvular stenosis such as aortic and pulmonary stenosis account for another 15%, while among cyanotic heart disease like tetralogy of Fallot and inverted great arterial connections account for another 10% of the total burden of congenital heart disease. So, data examining the Indian scenario reported an overall prevalence of congenital heart disease as 1.3 to 13.28 per thousand live births, while the prevalence of severe congenital heart disease to be reported as 1.5 to 1.7 per thousand live births. In general, approximately 2.5 lakh children are born with congenital heart disease in India every year, and nearly 1 in 5 often needs an early intervention to survive. In a very pertinent classification provided by Dr. Professor Anita Saxena from AIIMS Delhi in 2016, it is useful to classify these diseases based on their functional or hemodynamic significances into insignificant, such as very small muscular ventricular septal defect that is likely to be closed spontaneously, and significant that can be further divided into minor and major types. The minor congenital heart diseases are acyanotic congenital heart diseases with small left to right shunts and mild valvular aortic and pulmonary stenosis with gradients less than 25 mm of Hg. While the major congenital heart diseases are those that requires intervention usually within first year of life, and these includes acyanotic congenital heart diseases with a large left to right shunts and all cyanotic congenital heart diseases. So the timeline of the major achievements in interventional pediatric cardiology reveals that compared to surgery for congenital heart disease, interventional cardiology is much more recent specialty, with most procedures being developed and refined much later. to highlight a view such as closure of patent ductus arteriosus, pulmonary wall, balloon dilatation, atrial septal defects closure, and intervention for coarctation, ventricular septal defect, and aortic stenosis have been continuously evolving, and some of them, few procedures have now gained acceptance as being established for percutaneous intervention in congenital heart disease, including atrial septal defect, patent ductus arteriosus, ventricular septal defect, and ruptured sinus of Valsalva, congenital pulmonary stenosis and aortic stenosis, coarctation of aorta, and coil embolization for the major aortopulmonary collaterals, and interventions for native pulmonary artery stenosis and ductal stenting for duct-dependent circulation lesions. So now I will invite Dr. Ankit Sahu sir to share our experience of the SGPG.
Thank you, Dr. Sajid. Now, I will be briefly discussing our experience with congenital heart disease interventions. Here is our data from the last 5 years encompassing more than 200 congenital heart disease intervention. Due to COVID, there was a slight slump noted for 2 years. However, the number have again picked since then, and we have reached the pre-COVID era levels again. Of all the congenital heart disease interventions, ASD device closures make up the major chunk, accounting for almost 40% of the cases, followed by patent ductus arteriosus device closure and pulmonary valve balloon dilatations. Together, these three procedures alone account for almost 80% of all cases. This is the breakup of overall interventional data according to different lesions. The atrial septal defect closures and the patent ductus arteriosus closures are the most commonly intervened lesions, and after the resolution of COVID pandemic, the numbers have really picked up. Now, coming on to the age-wise distribution, overall the mean age of the patients intervened was 23 years, as this population consisted of children as well as some adults presenting with congenital heart disease later in their life. Patients having valvular aortic stenosis and patent ductus arteriosus presented early and therefore were intervened at a younger age as compared to other lesions. Likewise, overall sex distribution was 50-50, although some congenital heart disease such as atrial septal defect, PDA, had slight female predilation, whereas patients with valvular aortic stenosis and rupture of sinus of Valsalva aneurysm had male dominant population. Now, we will be briefly reviewing the salient features of some common congenital heart disease along with the evidence in the form of surgery versus percutaneous interventional data, our case examples, followed by key messages in the light of recent guidelines. These congenital heart disease will include atrial septal defect, patent ductus arteriosus, valvular aortic stenosis, valvular pulmonic stenosis, coarctation of aorta, and ruptured sinus of Valsalva aneurysm. In the light of these recent guidelines, 2018 American guidelines, 2020 European guidelines, and the Indian guidelines as well of 2019, we'll discuss the following lesions. First of them is the atrial septal defect. There are mainly 4 types of atrial septal defect, with the defect in the interlateral septum and resulting in a communication between left atrium and right atrium and the blood flowing from left to right. These are mainly of 4 types, and the most common one is the ostium secundum ASD, which is almost found 3/4 of the cases. ASD is one of the commonest congenital heart disease, often being asymptomatic and therefore presenting in 3rd, 4th decade of life in adults. However, large ASDs can be symptomatic in children also and present with recurrent LRTI and failure and poor weight gain. The long-term left to right shunting often results in a right heart volume overload, leading to pulmonary hyperemia and sometimes pulmonary arterial hypertension. As already told, it usually presents in 2nd or 3rd decade with shortness of breath, palpitations, and arrhythmia. The treatment options for ASD involve open heart surgery, involving median full sternotomy, minimally invasive surgeries, and lastly, the option is of transcatheter approach. Now, here is a data
This is one of the largest and the earlier meta-analysis comparing open heart surgery versus transcatheter closure, which is published in 2011. It included 13 studies from over a span of 10 years and included over 3,000 patients of a broader age group and follow-up of up to 1.5 years, and showed 5 times more risk of post-procedural complications in patients undergoing surgical ASD closure as compared to percutaneous closure. This is a recent meta-analysis comparing minimally invasive surgery versus device closure involving 6 observational studies with 1,500 patients and showing lower duration of hospitalization with percutaneous and transcatheter approach with a mean difference of 3 days, along with the lower rates of atrial fibrillation, pericardial effusion, pneumothorax and bleeding, which is mainly seen in the minimally invasive surgical cases. This is the 10-year follow-up data of long-term outcomes after transcatheter atrial septal defect closure. This included 14 studies with patients of over 2,000 patients and a follow-up of around 5 to 9 years. The success rate was in excess of 95% and a low complication rate, of which most common were atrial arrhythmias in the tune of about 5 to 8%. Our recent experience with the ASD device closures shows technical success of around 94%, a mean hospital stay of 2 days, with the device embolization being the most common immediate complication seen in around 3 to 4% of cases. This is one of the illustrative examples of atrial septal defect. She was a 4-year-old child with a history of poor weight gain, presented to us with an echocardiographic diagnosis of a large ostium secundum ASD with left to right shunt and a hemodynamic significant shunt. After due echocardiographic evaluation, she was considered for transcatheter closure. This is the atrial septal defect being closed by the device under echocardiographic guidance, and this shows the bilobed or the double disc device having a left atrial disc and a right atrial disc being deployed in the respective chambers. The left atrial being opened up in the left atrium, and then the right atrial disc being opened across the atrial septal defect on the right side of the atrial septum. This is the echocardiographic pictures in various views demonstrating the optimal position of the device deployment. This is the fluoroscopic images of the same, showing the ASD device being positioned across the septum and both the disc being opened up, followed by release of the device and the final position of the device in situ, closing the defect. So the message for the atrial septal defect is that the device closure is a reasonable option to the surgery, especially in suitable cases having adequate rims, and as it avoids cardiopulmonary bypass and myocardial handling, it leads to earlier mobilization, shorter hospitalization, and a good long-term success rates are available with us in the form of evidence-based data. Obviously, the device closure has to be in the suitable patients and to be avoided in patients having inadequate rims, thin rims or very large ASDs or non-ostium secundum ASD, and also sometimes in the multiple ASD the surgery is better. The guidelines recommend the closure of ASD by percutaneous method to be guided by echocardiographic, and the device closure to be considered in suitable patients having adequate rims, and the class of recommendation is class 1. The next lesion is patent ductus arteriosus. It is the communication between aorta and pulmonary artery, with the shunt being left to right from aorta to pulmonary artery. The various types of patent ductus arteriosus according to anatomy are there. Most common is type A, with the constriction noted at the pulmonary end. The PDA is especially common in the preterm neonates. In the term newborns, the functional closure usually occurs within 24 to 48 hours after delivery, and the anatomical closure follows up with around at 2 to 3 weeks duration. A significant PDA having significant hemodynamic shunt causes pulmonary volume overload, heart failure, and also may cause endocarditis. The treatment options are surgical ligation or transcatheter closure. The data regarding the surgery versus transcatheter closure of PDA. This is the recent data of around 700 patients from a US-based registry. It shows that the surgical patients had significantly higher mortality. There was no mortality in the transcatheter group, and the device closure resulted in the lesser ICU stay, lesser mechanical ventilation rates, and shorter hospital stay, with being no mortality seen in the transcatheter group. The long-term device data is also available. This was a meta-analysis in 2020 of around 90 studies having more than 2,000 patients, in which the technical success of the procedure was around 96%, irrespective of whether the centers were doing a large volume or a lesser volume of the caseload, having minimal procedural complications of less than 1%. Our experience shows the technical success to be more than 98%, with a post-operative duration stay of around 24 hours without any death or device migration. So this is a case of patent access arteriosus in a 2-year-old male having history of recurrent lower respiratory tract infection, detected to have a murmur, and on echocardiography a large PDA was diagnosed with a left to right shunt. This is the antegrade PDA closure wherein we cross the PDA from the venous side into the arterial side and deploy the device. So the arrow shows the anatomical location of the PDA in the angiograms, and the subsequent deployment of the duct occluder deployed via antegrade approach. This is the duct occluder being released, and finally the PDA is being closed. As shown in the angiogram, there is no flow from aorta to pulmonary artery. Pulmonary artery is not filling. So the defect has been closed antegradely. This is the second case of patent access arteriosus in a 17-year-old female presenting with dyspnea and a history of recurrent LRTI in the childhood, detected to have a large PDA with hemodynamically significance. She was taken up for transcatheter closure. However, the unusual ductal anatomy in the form of tortuous vertical duct resulted in failure to cross the duct antegradely through venous side, and therefore we have to resort to the retrograde crossing of the PDA from the aortic side into the venous side and forming of an atriovenous loop. As you can see, the loop is formed from the catheter goes from the arterial side, crosses the duct and comes to the venous side, and there the wire from the venous side is being snared and pulled back through the femoral venous access sheath. And thereafter the device is being deployed and the duct is closed with a ductal occluder successfully. This is the third case of the patent access arteriosus with a 7-year-old male child. He was an obese child with an ambiguous genitalia, history of recurrent LRTI, presented with a large PDA, non-restrictive PDA, and having some moderate pulmonary hypertension. So he was taken up for transcatheter closure. The descending thoracic aortogram showed a large duct. The ductal occluder was deployed and the device confirmed the optimal position. However, subsequently, while unscrewing the cable, due to the cable tension, the device dislodged just prior to the separation. You can see the device being dislodged from the site in C2 and is now in the pulmonary artery. So this is a case of the application of different device being used for ductal closure. So in this case, we opted for a double disc device in the form of muscular VSD occluder, which was released and the duct was closed successfully without any significant obstruction of the aorta or left pulmonary artery. So the message is that the transcatheter closure is the method of choice for PDA closure, and it represents a progressively increasing proportion of the PDA closures as seen in our data as well as the global data. The procedural success has increased over the time because of the innovations and improvement in the hardware, and it results in more number of procedures being performed in smaller and younger patients as and when the time goes, and it is preferred over surgery. The guidelines say the device closure in child weighing more than 6 kg is class 1 recommendation. In less than 6 kg it is class 2B. However, with the advent of the new devices, the neonatal PDA closure is also now being done. The next lesion is aortic stenosis. So aortic stenosis, normally the valve is tricuspid, but when the valve is inherently deformed and the leaflet is defective, it leads to bicuspid or unicuspid valve, resulting in inherent stenosis and or associated with regurgitation. So the congenital aortic stenosis accounts for almost 5% of all congenital heart disease, and they usually present with with congestive heart failure in infancy or childhood if the lesion is significant. The surgical aortic valvotomy is an option which encompasses the commissurotomy, valve repair, and ultimately the valve replacement. The other option is the balloon aortic valvotomy, and with the advent of the lower profile balloons, this is as the results are as encouraging as surgical valvotomy, as shown by the Congenital Heart Surgeon Society in 2001, which documented similar outcomes between the two techniques in neonates and suggested bicuspid balloon aortic valvotomy as the initial treatment, as the morbidity and mortality was slightly lesser in balloon aortic valvotomy group. The data comparing surgical valvotomy versus balloon valvuloplasty for congenital valvular AS shows that there was no significant difference in the 30-day mortality, or there was no significantly increase in the AR. Also, there was no significant difference in the freedom from AVR in the long-term follow-up. However, the 10-year reintervention rates were higher in the balloon aortic valvotomy group, as these children needed multiple reinterventions versus the surgical valvotomy group. The long-term balloon data suggests that even at 7 years follow-up, the freedom from future aortic valve replacement was 96% in the balloon aortic valvotomy group. This is the recent data at 1 year, and at around 10 years follow-up it is 86%. So 86% will not require future aortic valve replacement if the balloon aortic valvotomy was done in the neonate era. However, the aortic valve replacement, the need for aortic valve replacement is commonly observed in unicuspid unicommissural valves in patients with less than 1 month of age, in which they were intervened at less than 1 month of age, and in those patients who had residual gradient even after the balloon aortic valvotomy. This is our case of valvular AS. This was a neonate. He presented with poor feeding since birth. He was acyanotic. Admitted in an ICU for congestive heart failure and AKI, and detected to have bicuspid aortic valve with severe valvular AS and severe LV dysfunction. So she was considered for aortic valvotomy, balloon aortic valvotomy, and the ultrasound guided femoral arterial access was taken, followed by LV angiogram and the crossing of the aortic valve and subsequent balloon dilatation. This is the intraoperative echocardiography showing a linear echogenic focus in the suggestive of wire in the LV cavity and the resolution or the reduction in the gradients thereafter. So our message is that the aortic valvotomy is safe and efficacious in symptomatic neonates and infants. It is less invasive obviously as compared to surgery, but has higher rates of reintervention. And the guideline do not preferably suggest that you should use either approach, but it should be institutionalized and individualized on the patient characteristics and preference. And it should be avoided, balloon aortic valvotomy should be avoided in cases of severe calcific AS, unicuspid valve, and significant AR. The guidelines do suggest that neonates which have a drug-dependent circulation or who are quite symptomatic and having LV dysfunction should be intervened by a balloon aortic valvotomy, with a class of recommendation being Woodman. Next is pulmonary stenosis. The pulmonary stenosis can occur at various levels. It can be subvalvular, valvular, supravalvular, or even in the pulmonary artery itself, resulting in peripheral PS. Congenital valvular PS is the commonest of these and accounts for almost 3 to 5% of all congenital heart disease. In this video, we can see at the top the pulmonary valve, which is thick and domed and stenosed. These patients could be asymptomatic with an incidental murmur. If the patient has severe or critical PS, it can present even in the infant age group with an early onset heart failure. Valvular PS may occur alone or in association with other congenital heart disease like VSD, PD or ASD. Peripheral PS is also associated with several syndromes like rubella, Williams, Noonan syndrome, DiGeorge syndrome, Ehlers-Danlos syndrome or Lippard syndrome. The treatment for pulmonary stenosis, there are two options. One is the pulmonary balloon valvuloplasty (PVBD), which is safe and efficacious. The other is balloon dilatation and stenting for the peripheral PS, which is the treatment of choice for the focal stenosis. The success rates are in excess of 95% with the complication rates of pulmonary valve significant pulmonary valvular regurgitation being less than 1%. And the 10-year follow-up data also suggests that the restenosis rates are quite low, 2 to 3% in cases being subjected to pulmonary balloon valvuloplasty. The surgical interventions is only reserved for those cases in those patients who have non-valvular PS, dysplastic pulmonary valve, hypoplastic pulmonary annulus, or failed balloon dilatation. Such valves who do not respond to balloon dilatation. Our experience suggests that the technical success was achieved in almost 99% of cases, with a moderate PR was seen in only 2 cases on follow-up. This is a case example of 6-year-old male presenting with fatigue, detected to have some murmur, and on echo was diagnosed to have severe valvular pulmonary stenosis. This is the right ventricular angiogram, left panel, showing thick and domed pulmonary valve with a streamlined jet of dye being thrown from RVOT into the pulmonary artery, dilated pulmonary artery. So then the patient was subjected to pulmonary valve balloon dilatation, and this is the second case of a 37-year-old male presenting with progressively increasing fatigue and pedal edema, detected to have a murmur, and on echo he was diagnosed to have peripheral PS in the form of severe discrete stenosis of right pulmonary artery with an aneurysmal dilatation of main pulmonary artery and RV dysfunction. Subsequent CT showed a discrete membranous stenosis in the proximal right pulmonary artery with an absent LPA. This patient was taken up for pulmonary for peripheral PS ballooning with stenting. So this is the pulmonary artery angiogram showing severe stenosis in the form of a membrane. Proximal right pulmonary artery. This was dilated with the balloon, and subsequently the stent, bare metal stent, was placed and was expanded. This is the final angiographic result, with the stenosis is being resolved, and the patient's RV dysfunction is improved on subsequent follow, and the symptoms also resolved. So the message is that pulmonary balloon valvuloplasty is a safe and effective method for treating pulmonary valvular PS patients. It is less invasive and treatment of choice for valvular or peripheral PS. The guidelines suggest that the neonates who have critical PS with drug-dependent circulation, or the children who are symptomatic having RV dysfunction or having RV hypoplasia, should be subjected to this procedure. And for the peripheral PS, patients having focal stenosis, the balloon dilatation with or without a stenting is the treatment of choice, and with the class of recommendation being 1. The next lesion is coarctation of aorta. So coarctation of aorta accounts for almost 2 to 8% of all congenital heart disease and often associated with bicuspid aortic valve, with the presentation being bimodal. In neonates and infants, it may present with early onset congenital heart failure, while in older children and adults usually present with refractory or resistant hypertension discovered incidentally on workup. The treatment options include surgical repair, and the other option is percutaneously or transcatheter balloon angioplasty with or without stenting. So the data comparing the outcomes of surgical versus balloon angioplasty for native coarctation as well as the long-term transcatheter interventional data from the impact registry, the recent data suggests that there is the lesser rate of immediate and early complications with balloon angioplasty. Almost there is 1.7 times more risk with the surgery, and the re-intervention rates were also higher with the balloon angioplasty group because they might be restenosis, or the residual stenosis might not respond to balloon angioplasty. So there is a chance of higher re-intervention rate with balloon angioplasty, but with a lower complication rate as compared to surgery. This is a case of a 35-year-old male presenting with easy fatigability and dyspnea and resistant hypertension. On workup, he was diagnosed to have a differential blood pressure in upper arm and lower arm, with a systolic murmur being present in the infrascapular region. The pulses of lower limb were feeble, and he was diagnosed to have coarctation of aorta in the proximal descending thoracic aorta just after the origin of left subclavian. On CT angio, showed short segment near interruption of descending thoracic aorta. It was taken up for transcatheter balloon angioplasty with stenting of the coarctation. This is the angiogram showing simultaneous proximal and distal aortic angio, showing the length of the coarctation segment, followed by wire crossing of the coarctation segment, and the subsequent stent inflation, deployment, and the final angiographic result. The guideline recommendations for coarctation of aorta is age dependent, and the neonates which present earlier in the course of life, the surgery is preferred over balloon angioplasty. However, those neonates who are critically ill or are not fit for surgery in the view of high risk shock or severe heart failure, the balloon angioplasty is is a reasonable method to tide over the crisis. In infants with native coarctation, surgery is better. However, children with less than 25 kgs with native coarctation, balloon angioplasty scores over the surgery, and in adults and older children with more than 25 kg of weight with native or recoarctation, stenting is preferred and is class 1 recommendation. However, the stenting of aorta is contraindicated in children less than 10 years because the aorta size is not developed to the adult still in this age group. The next lesion is ruptured sinus of Valsalva, in which there is progressive elongation, dilatation, and aneurysm formation of the sinus of Valsalva with the subsequent rupture into any of the 4 chambers of the heart. So this results from the defect in the aortic media, and most common site is right coronary sinus aneurysm followed by non-coronary sinus involvement, and it usually ruptures into right ventricle or right atrium, right-sided chambers, and results in the volume overload and heart failure, and it is often associated with VSD and aortic regurgitation. The presentation is in the form of congestive heart failure. The treatment options include surgical repair or percutaneous closure. The data from the outcomes of repair of RSOV, the long-term data recently from in 2021, and meta-analysis, they suggest that there is lesser in-hospital complication with the device closure, although device embolization may occur in 3 to 4% of cases, with the subsequent surgery being required in these cases. There may be a trivial to mild residual shunt with the device, which may disappear over time and also may result in some hemolysis over the time, which may resolve on its own. The new onset AR is also seen in less than 5% of cases, which is seen in both with surgery or percutaneous closure. And with the long-term follow-up, the event-free survival was in excess of 95% in the both groups. So this is our case of 26-year-old male presenting with dyspnea and NYHA class 3 for the last 6 months, having continuous murmur and detected to have ruptured sinus of Valsalva aneurysm to right ventricle. This was a massive shunt, and the patient was taken up for percutaneous device closure. This is the aortic aortic sinus angiogram showing the shunt from the right coronary sinus to the RV. This is the formation of, then this defect, to close the defect was crossed from the aortic side and the wire was crossed subsequently into the right ventricle, right atrium, and into the IVC, thus thereby forming the atriovenous loop, and followed by subsequent deployment of the device, and the defect being closed with the duct occluder, closure of the defect successful. So the message is, when compared to the surgical treatment, the device closure is quite safe and efficacious, less invasive, and useful especially in patients who are having inherent high risk because of the resulting, these patients present in refractory heart failure or intractable heart failure. And this should be avoided, this percutaneous closure should be avoided in very large defect or associated significant AR or VSD. Still, there is no randomized study come between the two modalities. Now we'll be presenting some interesting other congenital heart disease intervention. There is an 11-year-old male with cyanotic heart disease diagnosed as tetralogy of Fallot, and the cath study revealed multiple collaterals. So he was planned for intracardiac repair, surgical correction, and prior to surgical correction, the surgeons needed coil embolization of the collaterals. So this is the coil embolization. This is one of the collateral from the right subclavian artery branch, coil being deployed and the collateral being subsequently closed. These are the other collaterals which are being closed subsequently by the coils, resulting in reduced collateral flow, and this was followed up by the surgical closure and definite closure of the defect. This last case of 19-year-old female presenting to us with cough with hemoptysis and detected to have a continuous murmur. X-ray, however, showed a large, homogeneous, well-defined round opacity in the left lower zone as well as features of PH. Echo and CT evaluation revealed a large PDA with multiple pulmonary atriovenous malformations and the evidence of PH. So, firstly, the PDA was closed with a duct occluder antegradely, and the selective pulmonary artery angiogram showed a large pulmonary AV malformation which was being supplied by the left pulmonary artery, and this malformation was closed with a duct occluder. And you can see in the last angio, there is no dye being in the AV malformation. On CT follow-up, subsequent follow-up, we can see that initially there was a large pulmonary AV malformation in which the dye contrast filled the defect, filled the malformation, whereas in the subsequent CT follow-up, we can see the vacuole and there is no contrast now being in the AV malformation, and its size is also being reduced. So this shows the resolution of the AV malformation with the subsequent reduction in the size. So I now invite Professor Kapoor to conclude the meeting by presenting some conclusions.
Thank you, Aditya. So, the data looks very promising. So, I'm thankful to Dr. Savitri Srivastava, who actually trained most of us in pediatric cardiology, followed by Dr. Radhakrishnan, and then of course Dr. Naveen took up the mantle. All of our departmental other colleagues have also contributed to all these cases, and of course now Ankit is actively involved in this. So as I said, the data looks good, but at least we have to have some introspection into this, that despite a huge burden of congenital heart disease in India, as Dr. Ankit also said, this point needs to be reiterated that only 1/5 of these patients who have actually serious congenital heart disease and need intervention, less than 5 to 10% of these patients actually get advanced cardiac care which they deserve. So some people who are fortunate to come to tertiary care centers get this care, but many of these people don't get care. And the major challenges which at least at institutional levels we need to address is financial constraints. Of course, these patients have, the healthcare behavior community, these people are not very aware, they don't know where to go. So I think apart from spreading community awareness, education, percolating screening more deeply into the social sector, teaching these patients where to seek advanced medical care. At least at the government level, we need to have a more robust policy for developing congenital heart disease with better distribution of centers of excellence. There is a lot of published data which we can show that most of these advanced centers are, of course, distributed in the urban centers. There is a distinct south-north divide as well, that in the south parts of India, the percolation of surgical or interventional techniques for congenital heart disease is better. North comes second, and east and west are at a distal third and fourth. As far as institutions are concerned, I think we need to have better structured pediatric cardiology and surgery training programs so that more people get actively involved in pediatric cardiology, so that these patients can get the care which they deserve. And lastly, I think another thing which needs to be considered is the cost challenges. So cost constrainment through more innovations, because most of these devices are a bit costly. The cost is coming down of late, and of course, government support through financial schemes, because many of the times even surgery is expensive, the devices are expensive. So everybody is doing their bit. But I think we need to do a bit more. Yeah. Thank you.